Thank you very much, and I'm honoured at the invitation to give this lecture this evening. I think this is the first time I've been called a leading voice in anything, and it's certainly not a leading voice in public health before. Maybe that's a lecture series rather than people who are giving it. I'm very pleased to be here. I think I was last in Tennessee almost 30 years ago, and I was a recipient of something that was then known as the Harkness Scholarship, given by the Harkness Foundation, and it was for British students to come and spend a year or 2 years in the United States. And sadly, it doesn't exist anymore. It was a rather remarkable scholarship, because in addition to the generous stipend, I had a standard of living I didn't reach again for quite a long time. The condition of the scholarship was that I had to travel for 10 weeks. And they gave me a map of the United States, divided into 6 sections. And it was a condition of my scholarship that I had to visit 4 of these 6 sections, and they gave me 10 weeks travel money to do it. And my now wife was here in the country as well at the time. She was in Philadelphia. So we rented a car in Philadelphia, drove through the south, coast to coast, and back again. And we did clip the corner of Tennessee, I think, at the time. And that trip also brought me in contact with US law enforcement. I got a speeding ticket in South Dakota. In fact, it was a ticket for wasting fuel in South Dakota. The speed limit was 55 miles an hour. It's been reduced to 55 miles an hour because of the oil crisis. And so I was caught going 69, so I wasn't speeding, I was just wasting fuel. And I think it was on the same trip that I almost got another citation, and this was for standing too close to a bear in a national park. And it might have been Shenandoah. I don't think it was, but I'll pretend it was because we don't get the local interest out of it. So, I wish I had been given that citation now, because it would have been a much better story. But I was just warned off standing too close to a bear. Now I realise, of course, these were both public health interventions. The speeding was to, at least in part, to save me, as was, I believe, the idea I shouldn't be closer than 100 yards from the bear if I see one. So anyway, my talk tonight, what's wrong with health inequality and what can be done about it? It comes out of a number of issues that came to me almost by chance. So I work at University College London, and we have a very strong medical school. We have a very strong department of epidemiology. And within epidemiology, at my university, UCL, Michael Marmot's work in particular is very influential. And it was talking to students and collaborators with Michael Marmot that I realized there was something going on in epidemiology that should have been much more interest to political philosophers than we realized at that point. And I think the same realization was going on all around the world. Actually, the people who were seeing things coming out of public health that should make us think about political philosophy in a slightly different way. I'm going to talk a little bit about that. So I'm going to raise 3 questions today. One is health inequality, what's wrong with health inequality, and what can be done about health inequality. And I warn you now that what I'm going to say about the last one is going to be rather disappointing. So what is health inequality? Now, health inequality is slightly different to the way we think about other types of inequality. So when we think about income inequality, what we will do is plot the income of each individual and look at the resulting graph to see what level of inequality there is in society. But when we think about health inequality, that wouldn't be a very illuminating graph to draw. And suppose we thought about plotting the life expectancy of everyone in the country, or rather age of death, say, to make it simpler. So suppose we draw a graph that has age of death. Well, that would be interesting. It would be interesting to do cross-national comparisons, for example, or it would be interesting to do comparisons over time. But if you looked at a graph that just gave you individual ages of death, what would it tell you? Well, it would tell you some people live longer than others. Well, we knew that already. So when we're interested in health inequality, we're not so interested in individual factors, but rather disparities between groups. So what we will tend to do is to think about groups of individuals and to think about the way in which their health may be different within different groups. So this gives us two questions actually. One is, what are the relevant groups? And the other is, what do we mean by health? That is, if we're going to talk about inequality, then we have to have something we can measure, or at least roughly, and talk about one group having more of it or less of it than another. Well, what are the relevant groups? Let's start there. What groups should we be considering? Well, in different countries we take different groups. So this is something from Michael Marmot's very important book, Status Syndrome, talking about health inequality in the US. And so he's giving an example here of starting in downtown Washington, DC. Travel from southeast downtown Washington to Montgomery County, Maryland. For each mile traveled, life expectancy rises about a year and a half. There's a 20-year gap between poor blacks at one end of the journey and rich whites at the other. So he's supposing to start in the centre of Washington, DC. Life expectancy there is about 20 years less than in the wealthy suburbs. And he claims you can more or less measure life expectancy by the distance from the centre. As you travel along, life expectancy goes up as you get out of the centre city. So there you can see he's measuring health in terms of life expectancy, and he's dividing groups, in this case, between the poor blacks and the rich whites. Okay, so that is both economic and racial classification. In the UK, we tend not to place so much emphasis on racial difference, although those figures are kept as well. But we tend to be much more interested in social and economic status. So here, this is another one of Michael Marmot's illustrations. This is a table. And we have on the left-hand side the place, on the right-hand side life expectancy at birth. And you can see there, United States, Washington, DC, life expectancy at birth. This is for men, 63, United States, Montgomery, towards the bottom, 80. And you see the United States in the middle there, same as Cuba, and a bit ahead of Mexico. But the reason I'm putting up this slide is not for those figures, but the ones at the very top and the ones at the very bottom. So the United Kingdom, Scotland, Glasgow, Calton, life expectancy for men is 54. In United Kingdom, Scotland, Glasgow, Lenzie, North, life expectancy for men is 82. And these districts are 6 miles apart from each other. So this is a much more staggering health inequality than even Washington, DC. So what explains it? Well, I don't know how well you can make this out. I think this explains it. This is a bottle of whiskey. So the Scots are famous for many things, but among them, one is hard drinking, and the other is healthy outdoor sports. And you can see the two things put together there on the label of the Scotch whiskey bottle. I was amazed to be told when I checked in at my hotel that there's the biggest selection of whiskies in the south, just over there. If that's my direction, 150 whiskies behind the bar. But I was very disappointed to find that this one isn't there, Spey Cask. But there you have Scotch whiskey, and you have the fly fisherman. Now, roughly, and of course this is a very crude oversimplification, you can split Scottish men into 3 types. There are those who just drink the whiskey. There are those who drink the whiskey and engage in healthy outdoor sports. And then there are those who engage in healthy outdoor sports. And there's a lot of temperance as well in Scotland, as well as heavy drinking. And roughly speaking, the people who live in Carlton, where male life expectancy is 54, are drinking a huge amount, they're smoking a lot, they're injecting drugs, not all of them of course, they're fighting, taking risks on the road, taking all manner of risks with their health. And so life expectancy is 54, whereas the very wealthy people who live 6 miles out of Glasgow, they're drinking in moderation, if drinking at all, they're fly fishing, they're playing golf, they're looking after themselves, and they're living to the age of 82. So those are just pairs of examples. So they're extreme cases, but the next question is, what does the general picture look like? And this is what it looks like, and I will forgive you if you can't immediately work out what's going on in this graph. It's yet again one of Michael Marmot's graphs. What it has is 2 lines, one with light green dots around the line and the other one with dark green dots around the line. The top one, so each dot represents a neighbourhood, and they range from left to right in terms of deprivation. So neighbourhoods on the left are most deprived, neighbourhoods on the right are the least deprived. And the light green dots measure life expectancy, and the dark green dots measure something slightly different, which is healthy life expectancy. So healthy life expectancy adjusts life expectancy for years of disability or disease or other forms of illness. So if you look at the top graph, we've got a gradient in health. So Marmot and others call this the social gradient in health. The people who live in deprived neighbourhoods, the average life expectancy for the most deprived is, well, the line drawn as the average there is what, 73 or so. The average life expectancy in the least deprived neighbourhoods is, as we've already seen, around 83, 84. So there's a difference in life expectancy of close to 10 years on the average of those neighbourhoods. And then if we look at the graph below, it's even more striking that in terms of healthy life expectancy, those who are living in deprived areas have much worse health as well as shorter life. And so the difference in healthy life expectancy is, what, about 17 years. So this is the UK social gradient in health. And we've been worrying about this for a long time. We've certainly known about the social gradient in health for more than 100 years. And this is the current picture. So in the UK then, we observe a relationship between socio-economic status and life expectancy, and an even stronger relationship between socio-economic status and healthy life expectancy. Now, remember, these are figures on the average, so of course, someone from a deprived neighbourhood might live to the age of 100, someone from a wealthy neighbourhood might die at the age of 50. These are average figures, but the average is very striking. Now, Marmot and his colleagues have looked for social gradient in health just about everywhere in the world. And they've found it in most places and at most times throughout history. Not all times, so there have been times in history where it's actually been better from a health point of view to be poor. So for example, in 19th century Sweden, it was better to be poor than rich in terms of life expectancy. Surprising phenomena. But what appears to be the case is the closer you live to a main road, the more likely you are to die of infectious disease. And the poor lived in the countryside and the rich lived in the towns. Towns are very bad for your health, historically. I think things are a bit better now, but for a long time, living in a town was a way of dying of infectious disease. Roy Porter, the medical historian, claims that in the times of the 19th century, cities like London and Paris would not have been able to reproduce themselves if it hadn't been for fresh supplies of immigrants coming in from rural areas permanently. So more, in other words, the death rate was higher than the birth rate in a lot of cities in the 19th century. Thankfully, those claims are past. Okay, so this is the British picture, or at least one way of presenting the British picture. Of course, you might say that's not the most illuminating way. So deprived neighbourhoods, you might want to know how does that correlate with other factors, race, religion. We can do a social gradient in health and religious belief. And it turns out that people with strong religious belief living in religious communities live longer than people who don't. Make of that what you will. But we can sort people according to all manner of groups. In the UK, as I've said, we tend to do it by socio-economic status. In the US, you do something else, which is typically to divide by racial group. So here is a figure from 2012, refers to 2010 figures, although they have not changed very much since then. And here we see something very, very interesting, and perhaps to some people very surprising as well. So if you look at the table on the right-hand side, figures for 2010, life expectancy at birth. By the way, let me say just one thing about life expectancy at birth as a measure. When I first came across life expectancy at birth, I thought it was the same thing as average age of death, and that you could get life expectancy figures by looking at who's dying. Well, of course you can't, because we're talking about the life expectancy of someone who's born today, not someone who died today. And how do you know that? How can we possibly know the life expectancy of someone who's born today? If we go back, say, 50 years and ask what was the life expectancy supposedly of someone who was born 50 years ago, it wouldn't be anything like their actual age of death, because life expectancy has increased in a completely unexpected way over the last few decades. So life expectancy at birth is a theoretical notion. It makes assumptions about disease patterns, lifestyle patterns, and so on. So although we tend to treat these as factual issues, they are a compound of statistics, or they're derived from mortality tables in a way which may turn out to be false. Having said that, that's still the best that we have to go on. And if we look at life expectancy for men, for black men, 71, for white men, 76, and the surprising, perhaps not surprising to many of you, statistic for Hispanic men, 79. And for women, the same pattern, 78, 81, and 84. And on the left-hand side, we see a short time series going back to 1980, and looking just there at the trends for white female, white male, black male. Okay, so here we have health inequalities, and I will come back to this slide because I think it's illuminating in a number of ways for us. Okay, so answer to the first question, what are health inequalities? Well, health inequalities have to be, if they're going to be informative, have to be statements of inequalities between groups, not individuals. And so it's always going to be a theoretical question about which groups you choose. It's also a theoretical question about what health measure you have. And if on different health measures, different inequalities will look different. So life expectancy and healthy life expectancy we've seen give you different results. I don't have healthy life expectancy figures for the United States, but I imagine we would see the same deepening of inequality in that case, and that black male and female health is probably worse than white and Hispanic health, but that's speculation, I don't have those figures. So next question, what's wrong with health inequality? Now, the medical literature asks this in terminology that philosophers have not used. So in the medical literature, the tendency has been to ask a slightly different question, which is, when is a health inequality an inequity? Now, inequity has not, for some reason, been a term philosophers have used. I don't know why not. It seems quite helpful, actually, to talk about an unjust inequality, because after all, you might think that some inequalities are not unjust. But in any case, the two discussions are running in parallel. So what's wrong with health inequality? Well, this is a view from the British public health theorist Margaret Whitehead from 1991, but she came up with it earlier than this, was repeated many times. And this is really, in the medical literature, this is the standard definition of health inequity. It's been very, very influential, at least in the UK. I don't know whether it's also used here. But the claim is that health inequality is an inequity when it's avoidable, unnecessary, and unjust. So I'll run through what these mean, and then I'll raise a number of questions about them. So what does it mean to say that health inequality is avoidable? Well, the thought is that there are some health inequalities that are not anything that we can do anything about. They could be facts of biology. And in the slides I showed you about the United States, we saw that there was a difference between in life expectancy between men and women. This is now virtually universal around the world. Wherever you go, women on average live longer than men. That is a health inequality. Is it an inequity? Well, it'd be interesting for you to test your intuitions about this. I won't ask for a show of hands, but I doubt that many people think that there's some sort of inequity in the difference in life expectancy between men and women. Why not? Well, according to Whitehead, it would be because it's unavoidable. That it's a fact of biology that women live longer than men. I'll come back to that. But this is the, as it were, the official view. The second notion is that the inequality has to be unnecessary. Now again, this is perhaps a little peculiar on the face of it. Because you need to think about it, when could a health inequality be necessary? What would we mean by saying that it's necessary? And remember, if it's already passed the first test, it's got to be avoidable, but necessary. So when could a health inequality be avoidable but necessary? Okay, well, the standard example here is the health inequity that happens in most countries in the military. Who do we send off to war? The fittest young men. And we restrict the draft to people who we think can fight. As a philosopher, you can raise stupid questions. So, a stupid question we could raise is actually, is that fair? Is it fair just to conscript fit young men? Why not old men? Why not unfit people? Why not women? If we're going to conscript people, shouldn't we just have a ballot of everyone and see who we send off? And well, no. If you want to win the war, you'd better not do it like that. It might be fairer to do it like that, but that's not the way to do it. In the British Army in the 19th century, they used to sell commissions, i.e. if you wanted to be a colonel, you could buy the job, roughly speaking. This was a great policy in peacetime, not so good in wartime. And, it didn't do us much good. That was eventually abolished. Okay, so it's thought that there could be necessary health inequalities. So if a country is industrializing rapidly, there could be industrial injuries, and that would be seen to be a necessary health inequality. Now we have the final one, that health inequality is an inequity when it's unjust. Now this may seem like it's just begging the question, because weren't we trying to find out when an inequality is unjust? We're told it's unjust when it's unjust. It's certainly true, but not very helpful if we're trying to get to definition. So why put in this notion of a health inequality when it's unjust? And the idea here is to get to the thought that actually sometimes there's a health inequality which is avoidable, unnecessary, but nevertheless completely just. Examples: skiing injuries. Okay. So if you break your leg skiing and other people don't, is it an injustice that you've got a broken leg and other people haven't? Well, it was avoidable, you didn't have to go skiing. It was unnecessary, it wasn't part of the national plan that you went skiing. But it's perfectly just for you to bear the consequences of your own free action in this example. So, the Margaret Whitehead example then is a health inequality is an inequity when it's avoidable, unnecessary, and unjust. Whether something is unjust depends on reasoning from political philosophy. Whether it's unnecessary might be something to do with industrial or military policy. Whether it's avoidable or not is a matter for public health or the medical profession to say whether something is a fact of biology or something we can deal with. So her view is that a health inequality is an inequity when it meets these three conditions: avoidable, unnecessary, and unjust. But this is problematic. Take the young soldiers being sent off to war. We might say that it is necessary to send them off to war. But that doesn't mean that we think it's just that these individuals bear all the burdens, that we don't share the burdens out of them. And so in this country, for example, if people are injured, fighting for country, they get medical assistance that other people don't get. That can be seen as some type of redress or compensation for the injustice. So the fact that something is unnecessary, and injustice and inequality is unnecessary, doesn't mean that we can't do something about it. We might be able to compensate for it. Similarly, the inequality between men and women. Now, there is even a British health economist who's worked on issues of distributive justice, a man called Alan Williams, who in one paper considered the supposed injustice between men and women. And he said, well, women live longer than men. That is an inequity. It's true we can't do anything about it, but we can get the women to compensate the men for it. So women owe men compensation on the face of it. Although that is cancelled out by other things. But if it wasn't for the fact that, for example, women's health is typically not so good over the period of life. So when you talk about healthy life expectancy, for men and women it's about the same. But so on the face of it, it is an inequity. Even if it's unavoidable, we can still compensate for it. And in fact, it is perfectly avoidable. You just make sure women don't live longer than their husbands, as some cultures have done. So it is avoidable. It's avoidable in an extremely unpalatable and unjust way, but that was a different criteria. That was the criteria of justice. We're only talking about what's avoidable. So this is the levelling down argument. And it's a notorious point that you can almost always equalise. If you can't equalise by levelling up, you can equalise by levelling down. Now, this actually turns out to be more important than I realised when I was first writing this talk some years ago, and having looked at some of the figures we'll come back to, levelling down actually turns out to be an important issue. Anyway, this is the definition of health inequity that we see throughout the public health literature. Whitehead's definition: health inequality is an inequity when it's avoidable, unnecessary, and unjust. It has been rejected by philosophers over and over again on grounds that I have stated, but the public health literature on the whole hasn't caught up. However, there is also in public health literature another definition of health inequality, which is much more intuitive. This is Paul Braidman. A health inequality is a difference in which disadvantaged social groups systematically experience worse health or greater health risks than more advantaged social groups. And I think this is probably why we find the original statistics so compelling, because what they do, for the most part, is show that the group that is already disadvantaged, people who are deprived, for example, in the UK case, suffer a further problem. So it's a compounding of one disadvantage on top of another. And that's when we find it problematic. And this is almost certainly why you didn't find the example of male-female health inequality terribly compelling. And what we have is a disadvantaged group who have one advantage, rather than thinking this is something that needs to be taken independently, discussed on its own. Okay. Now, we have this definition, I think it's a good one, of health inequality. It's a difference in which disadvantaged social groups systematically, not just contingently, systematically experience worse health or greater health risks than more advantaged social groups. So now we come to the philosophical question. What is wrong with health inequality? Why are we so concerned about health inequality? And it's very interesting in the UK that the Labour government paid a lot of attention to health inequality, commissioned a lot of work, including Michael Marmot's studies, and it was considered to be part of the left-wing agenda to be very interested in all forms of inequality, and in particular health inequality. And so people in public health were very nervous when the coalition government, led by the Tory party, got into power, and thought that they're going to try to reduce emphasis on inequality. But the interesting thing is that they made no challenge to the idea of health equality. That is, the right wing in the UK were just as worried about health inequality as the left wing had been. And people all around the world seem to be worried about health inequality. But why is that? Is it because people are really worried about inequality? Well, I don't think so. The inequalities that I showed you on the earlier slide, they're very significant, but they're nothing compared to other inequalities in society. The difference between life expectancy of 75 and 80, say, compare that to inequalities in income in any developed country. Compare it to inequalities in wealth. Compare it to inequalities in housing. Compare it to inequalities in schooling. If we had got the inequality so small in any other domain, we would think we've just about finished. We've won the battle for equality. If we can narrow any of the other inequalities to the degree we've narrowed inequality in life expectancy, healthy life expectancy is a bit worse, but nothing like income disparities. So we have figures for income and wealth disparities of the top 1% owning 99% of the wealth or something, if you take the world as a whole, but nothing like that in health. So why are we worried about health inequality? Well, as I said, one theory is there's something special about inequality. There's another theory that would say it's not inequality, but there's something special about health. It's because it's a health inequality that matters so much. So this is, again, a type of injustice. Now, I think there's another way of looking at this. And again, I want to go back to the philosophical literature. I think this is a way in which the philosophical literature can help us think about an issue in public health. And this is the work of the philosopher Harry Frankfurt. Now, Harry Frankfurt was one of a number of, I suppose we could call it, left-wing critics of equality. So Frankfurt argued that the philosophers who are arguing for equality had really missed something important. Frankfurt said, what's important in life is not how much you have in comparison with others, but how your life is going. His most famous paper on this, he begins the paper with a joke. I think it's funny, you probably won't, none of my students ever do. But anyway, the joke is, first man, how are your children? Second man, compared to what? So, in other words, the point of the joke is to say that how your life is going should depend on how your life is going, not how it's going relative to other people. You shouldn't be looking around, seeing how other people's lives are going and comparing yours, see, is it better or is it worse? And he said that the concern about equality actually makes you look at other people's lives and think, is mine all right compared to that? No, it's not. So peculiarly, he thinks that the concern for equality moves us towards a type of materialistic ethic. And that a lot of defenders of equality would have argued for the opposite, that equality goes against a consumption and comparison ethic. But Frankfurt thinks that concern for equality is essentially comparative, and that is alienating. that it makes you concerned about what else is going on in your society rather than what's going on in your life and whether your life is life for human beings. Now, some years ago, I was at a seminar where someone said to Harry Frankfurt, "So do you mean we should never make comparisons? We should never compare ourselves to others?" Frankfurt said, no, and that's not what I mean. Consider this. Suppose I come home from work. I open the front door, the dog sees me and runs away. I go into the kitchen, there's a note from my wife that says, "Your dinner is in the fridge." My children are nowhere to be seen. One of them's up in a room, the other one's gone out. So I go to the fridge, I get my dinner out, I put it in the microwave, I eat it standing up, looking out of my window. I look into my neighbour's house, and this is what I see. So there's my neighbour. Actually, the drawing is right, the line underneath it is wrong. The line says it cuts it. Well, how has everyone wasted time and energy today? But the idea is that your neighbour is sitting around having a nice family meal with his friend, with his family. They're all talking about their day. They're excited to see each other. The dog is under the table wagging his tail. You can't see it in the picture. It is, I can assure you. So that's the American version. This, of course, is the European version of the same thing. And Frankfurt says it's perfectly legitimate for me to compare my life with my neighbour. But there are two separate thoughts I could have when I compare my life with my neighbour. One is, that's not fair. He's got a great life. I haven't. I should have a life like his. So that's a type of direct comparative judgment. And it makes me think things have gone badly for me because my life isn't as good as his. The other thought I could have is, that's what a good life is like. That's a model of a good life. It didn't have to be that anyone was actually living it. I could have seen it on a film, I could have read about it in a book. But it gives me knowledge about what else is possible for human beings. Now, this is a way of thinking about health inequality. That you might think health inequality is unjust. I'm not going to argue against that. But health inequality shows us what is possible for human beings. So if we look at the curve, think about the curves again, we've got groups that are not living up to what we know is possible for human beings. Now, we don't know that most human beings can live to 100. And no society has achieved most human beings living to 100. But some societies have achieved most human beings living to 79. So why can't every individual in that society live to the age of 79? Well, there are going to be reasons of biology, contingency that stops some. But we think if some people can live to the age of, well, in the Scottish example, 84, why are the others not living to that age? So, instead of thinking about it as health inequality as being unjust, it might be unjust, but in addition to that thought, we can think that health inequalities give us knowledge. In the philosophical term, it's an epistemological device to show us what else is possible for human beings. So just as a charming family scene like this is possible for human beings, actually I'm not even sure what that is, living to a longer age does seem to be possible for human beings, even if we haven't achieved it. So then we need to think, well, why is it that health inequality is as it is? What can we do to make a difference? Okay, so this brings me on to the third part of the talk, the final part. What can be done about health inequality? Why is it that we observe these differences in life expectancy and healthy life expectancy? Well, of course, the first thing that might well come to mind is that it has something to do with access to medical care. Some people have excellent medical plans, other people have poor medical plans. Now, in the UK, of course, we have the National Health Service, so everyone does have access to supposedly a good level of medical care. So it doesn't look like medical care alone should be able to explain the gradients in health, the social gradients in health. Now that may be misleading. there was a Welsh doctor called Tudor Jones who wrote a paper coining the phrase the inverse care law. And he said that the problem with, or at least one problem with something like the National Health Service, in fact any medical system, is that doctors on the whole prefer to live in areas where there are other rich people who don't have many diseases. And so if you leave things to free individual choice, you'll find that doctors live in nice places to live, and they're all competing for the same wealthy, affluent clients. Where there is a highest health need, there are the fewest doctors. And this is observed just about all around the world. I'm sure it's true in this country as well. And in rural areas where the need is high, there are probably fewer doctors per population. So even in a national healthcare system, like the UK, in Canada I believe it's even worse, where there's no difference in salaries, so why would you go work in a rural place if you prefer to live in the city? There is different access to medical care. And that may make some difference. That may make some difference. But on the whole, access to medical care probably explains only a small portion of the social gradients in health. Because after all, medical care is something that you need when you are already ill. Medical care, on the whole, does not keep you well. Preventative medicine might, public health might, but of course those are things, public health anyway is available to everyone, if it's available to anyone at all. Preventative medicine, okay, that may differ from region to region, but on the whole, what makes you ill are factors in your life rather than whether you have access to a doctor. The doctor may cure you, if you're lucky. I would say, hands up who's been cured of anything here by a doctor, but that would be an unfair question in the presence of the medical profession. You may have your illnesses contained or kept under control or managed, but cure, unless it's surgery, is quite a rare phenomenon. But in any case, the medical profession can make a difference to your health, but it's very unlikely to explain the difference in social gradient in health. Well, what does make a difference? Well, here I want to introduce the theory I mentioned very briefly, again associated with Michael Marmot, which is known as the theory of the social determinants of health. And so, on the theory of the social determinants of health, your health on average will be determined by factors that are outside the control of the medical profession. So, if you're living in a damp house, if you're doing a dangerous, back-breaking job, if you're breathing in noxious fumes, if you're living in a polluted street, all of these material factors will make a big difference to your health. So, the deprivation factor, of course, it was no surprise, I think, to anyone in this room that people living in deprived areas had worse health than people who are living in affluent areas. The quality of the air was probably better, availability of healthy food, the money to buy that healthy food, being able to take exercise in a safe place, kids being able to run around in the garden or run around in the park rather than on a dangerous street. All of these things will, over a population, influence health. So these are the material determinants of health. And a lot of the social gradients in health can be explained by these rather mundane factors, which is why issues like sanitation, clean water, are so important in so many parts of the world as they have been in the developed world. But there's other work by Michael Marmot and his associates that cast doubt on the idea that it's only the material determinants of health that explain the social gradient. And this is work which is somewhat controversial in explanation, but I'll introduce it and you can think your own, come to your own views about it. And this is a series of studies that Marmot and others did, known as the Whitehall studies. Now, the Whitehall is a place in London where the British civil service were located. So the Whitehall studies were studies of civil servants. And the researchers, epidemiologists, were invited into Whitehall in the 1960s to investigate the believed phenomena of executive stress. So do we remember executive stress? Executive stress is the idea that if you're at the top of a hierarchy, if you're the boss, you have a very stressful job, and that will be bad for your health, likely to cause you a heart attack. Therefore, you better be able to retire at the age of 50 with a very big pension. And the bosses in the civil service were very happy to sponsor research that showed that they had poor health because of the stresses of their job. So the first wave of researchers went in, they did a very systematic study, they did questionnaires that went to people at all ranks in the civil service. For some reason in the first wave they only did it for men. I'm talking about the 1960s here. So they surveyed men's health. Then when they came out with the results were the exact opposite of the hypothesis. That is, the higher up you were in the civil service, the better your health and the longer you lived. Permanent secretaries, which is the highest rank, lived longer than deputy secretaries. They lived longer than their assistants. And this gradient went all the way down to the postscript at the bottom. So there was a social gradient representing the status hierarchy within the civil service. Now, could this be material factors? Evidently not, because everyone working for the civil service was well above any poverty line. So there was no deprivation, they all had decent food, they all had decent opportunities for education, at least to some degree. They all had access to medical care, they were not living in damp homes, they were not living working in a polluted atmosphere, these were office workers. So what explained it? Well, people thought behavioural factors, it must be there's a social gradient in smoking, say, or alcohol abuse. To which there are two replies. One is that actually when you looked at that, there was still a social gradient even when you controlled for these factors. And secondly, if there is a social gradient in smoking and alcohol abuse, that's something that needs to be explained as well. Because we can't just take that for granted. Why is it that people drink more and smoke more? So other critics say this is about men, not women. So the next wave included women in the survey, and the same thing was found, although on a lesser scale. And after this, people have gone around the world looking for inequalities that are linked in some way to status. So you may have heard of this research that is done every year, renewed every year, or it comes out every year. Actually, I haven't seen it yet, but we haven't had the Oscars yet. Why do I talk about the Oscars? Well, it turns out that people who are actors who win an Oscar live longer than actors who are nominated for an Oscar but don't win. This is true for actors, it's not true for screenwriters. So you can puzzle that out for yourselves. Okay, so there seems to be a status hierarchy. And Marmot thinks there are three reasons for this. One is pure status effects. Just being higher up in the hierarchy is better for your health. Now that is something that no egalitarian like myself would want to believe. That we ought to be able to overcome these types of status effects. So I think I'm on a losing battle. The second hypothesis is that people who are higher up in the hierarchy have more control over their lives. So although they suffer from acute stress, they have big decisions to make, they have much less chronic stress. And it's chronic stress in this theory that is bad for your health. You have chronic stress if you have a demanding task with little support and little reward. So when I read this, I thought, I now know how to make the people who work with me ill. So if you want to, one thing you learn from this lecture, so if you want to make people you work with ill, what you should do is on Thursday night say, I need that report on my desk first thing Friday morning, and don't come in on Friday. So there's high demand, no support because they're doing it overnight, and no reward because you're not there to receive it. And you come in on Monday, you look and say, oh yeah, thank you, and file away without looking at it. I realized actually, once I've said that, this is roughly speaking what we do to students. And so, you know, when your students are complaining about their poor health, it's your fault, okay? So when you're in a situation of high stress, low reward, low support, then your health will be worse. And why is that? Well, supposedly a fight or flight reaction means that we will turn off routine healing, your digestion will be worse, your sleep will be worse. So, Michael Marmot thinks that there are social psychological determinants of health, and there is a social economic gradient for this as well. So if you live under stressful life conditions, your health will be worse. And if you're living under deprived conditions, you will be living under chronic stress. So for example, if you're always worried about your electricity being cut off, if you're always worried about whether you can feed your kids, if you're worried about whether your kids will go to school, these are all worries that don't go away. Whereas if you're the senior executive, you might have a big deal to pull off. You either do it or you don't do it. It's finished. You have a rest and go on to something else. Okay, so what can we do? Well, the move that people have made is to say, well, bear in mind the social determinants of health seem to explain the health gradient. What we need to do is to act on the social determinants of health. That is, if we want to achieve equality, we have to change the living conditions of people, the conditions of stress under which they live. And there's now a worldwide movement led by the World Health Organization to act on the social determinants of health. So there have been commissions on this in Brazil, in Chile, I think in South Africa, all around the world now, reports coming out on how to act on the social determinants of health. Will it cure health inequality? I'm not so sure that it will. One thing is, of course, the theory has to be true for it to have an effect. So the social determinants of health is still the level of hypothesis. But it may well be that even if we can change people's life circumstances, we may not change their behaviours. And it's really the behaviours, the risk-taking behaviours with health, that is making the difference. So we know about smoking and the effect that has on health. There's a social gradient in smoking. Why are poor people smoking? Well, whatever housing they're living in, whatever jobs they're doing, whatever pay they're getting, will that change the patterns of smoking? Maybe, maybe not. What we saw in the UK, after we introduced the National Health Service, we thought this would address health inequality. What we found, according to at least one authoritative report, is that 30 years after the introduction of the NHS, health inequalities had increased, not decreased. And that's because access to medical care is a relatively small part. Public health became much more important, and the educated middle classes were much more compliant in following public health messages, putting their seatbelts on, later wearing motorcycle helmets, not drinking so much, reading the labels on their food, being able to choose which foods to buy, and so on. So it's quite interesting. It's possible that doing more about the social determinants of health might make health inequalities even worse, because it's possible that the wealthier will do better to reap the benefits of social determinants of health. Now, it is a stubborn problem. Can it be solved? Well, go back to this slide again. Two things about this slide. I mentioned how interesting it was that the Hispanic group has the best health in the USA. I assume this is well known. I don't know if there are many hypotheses about why this should be so. If there are, I'd be interested to hear about it. But there's an interesting question here. Do we regard all of these inequalities as inequities or not? So the most obvious case, look at the male black and male white. The 5-year difference, is that an inequity? I think pretty much everyone who's interested in this area would say yes, it is. But look at male white and male Hispanic. Is that an inequity or not? Is it an inequity that Hispanic people live 3 years longer on average than White people, I think most people would say it's not. It's interesting, very interesting. It might give us some hints about how white people should change their behaviour, possibly, but it's not an inequity. And this supports, I think, Paula Braverman's view, because it's not a compounding of an existing disadvantage. That it's not that Hispanics are on the whole richer than white people, or at least not, as far as I know, the disadvantage is going in the other direction. So in a way we think of this as a compensating disadvantage. But now look at the left-hand slide. And look at the white male graph, which rises in a slow but fairly linear pattern. So it's the third one down, starts third one down and ends third one down. So between 1980 and 2010, life expectancy for white men has risen in the United States, but not in any spectacular fashion. For black men, it slightly went up, then it stabilized, and then it went up quite dramatically. And so between 93 and 2010, the inequality between black men and white men diminished by several years. So we might think this is very promising. Something must have happened that made it possible to narrow that gap. So what was it? What can we learn from that? Okay, so some of you, I think, are working out what this must be. So here's one theory. The shift appears to be because fewer African Americans are dying of AIDS and heart disease, but also because more whites are dying in early and mid-adulthood from unintentional injuries, mainly poisonings, including prescription drug overdoses, researchers said. So this is a Chicago Tribune reporting some Canadian researchers who've been looking at the US data. So remember what I said about levelling down? We've almost got some here. That the white male life expectancy is not rising as fast as other groups because of those behaviours. They haven't levelled it down, but the rise is slower than it might otherwise have been. It's very good that fewer African Americans are dying of AIDS and heart disease, and this is a result of medical interventions. So I may well have been too pessimistic about what medical interventions can do. Certainly in the last 20 years, maybe 30 years, we are seeing a difference in life expectancy because of things that are keeping people alive. The things that would have killed them before, killed anyone before, are now not such stubborn problems. But those types of interventions are going to be relatively rare. The types of things that people are dying of are not yet things that, on the whole, we have very good interventions to cure, although there's more life-preserving interventions that are possible. So what can we do to act on the social determinants of health or to cure health inequalities in other ways? Well, we're not really in a position to do very much about it, but the most interesting thing, I think, is the fact that life expectancy for all groups is rising. And if we went back far enough, we would see these lines crossing over, i.e. where black men are now is, roughly speaking, where white men were 30 years ago. So we've got continual improvement in all groups. Health inequalities may be unjust. What can we do about it? Perhaps we can even up medical care, perhaps that will help to some degree, perhaps we can act on social determinants of health, but there's no single intervention that seems to be the one that will make all the difference. This is very disappointing for policymakers, of course, because they want a single intervention, the golden bullet, the one thing you can say you've done. We have to do many things: reduce environmental pollution, improve housing conditions, reduce stress in people's lives, improve childhood nutrition, improve prenatal care, and there are going to be many, many things that make a difference. But many of these things will also make a difference for the wealthy groups as well. So I think although we can increase life expectancy for the disadvantaged groups, we're unlikely to be able to make a huge amount of progress on health inequality given what we have. That is the pessimistic message, but the more hopeful message is if life expectancy is going up, perhaps that matters less than we might have thought. But it remains an unsolved problem, certainly a problem a philosopher can't solve, of how we're going to improve the health of disadvantaged groups. But I think the figures we've seen show that we've got plenty to think about, and also, as the introductory remarks made clear, there are points of contact between what philosophers are doing and what people in public health are doing, and there is a chance we might learn from each other for our mutual benefit. Okay, thank you very much. Questions? Answers? I like answers.
Do you think part of the problem of inequality in England or in the United Kingdom might be because if people do have money, they can go to a private sector and get health care, whereas if they need what we call, voluntary surgery, they would have to wait a long time.
So it is certainly true that a lot of wealthier people in the UK have private medical insurance on top of national provision. Typically, this is a perk of a job. So if you're relatively high up in a company, you'll get this as a benefit. The interesting question is how much good it does. And so there are certainly things it does. So one of the problems we often have in the UK is it takes quite a long time to see a specialist. It varies from over what speciality, and it varies from time to time. But there's no doubt that often you can wait a month, 2 months to see someone. Then at the last minute the appointment's cancelled and you might have to wait another 2 months. So this is very frustrating. If you've got private care, you will see someone earlier. But the conventional wisdom is that if you're seriously ill, you really don't want to be in a private hospital in the UK. Because the consultants work business hours, they're there from 9 till 5, and then they go home, and there you are in bed with no qualified senior doctor around. They tend to be fairly small scale. And so if you're seriously ill in the UK, you want to be in a teaching hospital. You want to be in a university hospital, which is state hospitals. And all the best consultants, all the best care, certainly for life-critical care, is to be found in teaching hospitals, specialty teaching hospitals. So I think what the private sector is very good at is improving health for non-critical care. It's not really relevant for improving life expectancy on the whole, although there will be some cases where an early diagnosis will be beneficial. So it might explain a tiny bit of the social gradient, but I don't think anyone thinks that it's a significant factor.
One of the things that you mentioned piqued my interest. I did some research at Boston University, and you mentioned that giving access to healthcare doesn't necessarily fix the problem. You also have to create a paradigm shift or a change in the decision-making of people as well. Have you seen any epidemiological type of studies that combine both trying to give access to healthcare and changing the way people think about their lifestyles? And has that research been done? Because I have yet to see something that combines both.
Yeah. Okay. So as you, I'm sure, know, that quite a lot of work has been done to try to change behaviours, and some behaviours have changed. So when I was a teenager, I would regularly drive to the pub, drink a fair amount, and then drive home. I don't do that anymore. And I don't think many teenagers do that, because it has been understood that it is antisocial behaviour to drink and drive. I don't know what it's like around here. It seems that everyone has to have a car here, so if you're going to drink at all, you'll drink and drive at some point, I suppose. But in cities that I know of, it's very rare. Smoking ban, I think, and how successful that has been, caught a lot of us by surprise. In Europe, the smoking ban started in Ireland, where you would think people would have very negative attitudes to something like that, but it just took on. Wearing seatbelts in cars, that has also taken on, but that's something which is publicly inspectable. But what I find very interesting in these interventions that have worked is that they tend to work by pointing out that your behaviour is harmful to others, not yourself. So in a way this is cheering, because it means that we do have concern for other people. Now in the UK we would never have got the smoking ban if we didn't have this concept of, we call it passive smoking, I think you call it side stream smoke. And when anyone played a civil libertarian card that I can do what I want, someone can say, well, it's not only you that's affected, other people are being affected by it. Similarly with drunk driving. I think it literally did not occur to us when we were driving that we were a danger to other people. We thought we were a danger to ourselves and no one had a right to tell us what to do. When you start thinking you're a danger to other people, you take that more seriously. So when you can get these interventions which are good for the person and good for other people, I think those are possible. When you're just telling someone that it's good for you, then it's much harder. The campaigns that seem to work are ones that tell pregnant mothers that what they're doing is bad for their unborn child. That's the type of guilt trip that will work. And there was a very interesting campaign in the UK to get people to wear seatbelts in the back seats of cars. So even when seatbelts were being used in the driver's side and passenger side, very rare for people to put the seatbelts on the back of the car. I still never think to do it, or rarely think to do it. It depends on the driver, but as a matter of general course, I don't have that instinct to do it. There was a campaign, maybe you had something similar, of a family going along in a car and it said, like many victims, Mrs. Jones knew her killer. And then you had the car stopping and the teenage son at the back came forward and his head hit her on the back of the head and killed her in the advertisement. And so the idea was that by not putting your seatbelt on the back of the car, you're a danger to other people in the car. And there, again, I think it's playing on the same idea that if people think they're a danger to others, they can be made to do things that are better for themselves. But in terms of other programs, so there's a huge amount of money being spent all around the world on incentives for health, for paying people to do healthy things. And that was another talk I could give today about that. The worry about these programs is if you pay people to do healthy things, they'll start thinking you should only do them for the money, and they'll stop doing them when you stop paying them, which is called crowding out. What people who have these programs want is you pay someone to do something else, go to the gym, say. So there are programs where you get paid to go to the gym. And the idea is people go to the gym and they'll like it so much that they'll carry on going when they stop. Well, there's almost no evidence that this works. There are almost no cases where people have been given incentives to do something and when the incentive payment stops, it carries on. So I was talking about this in Germany, and someone said, actually, we do have a program in Germany where it's worked. And there's some complicated scheme about getting discounts on your insurance, your health insurance, if you went to the gym. And then people carried on going to the gym when they didn't have the discounts. So this is interesting. Maybe there's something works there. But it turns out that these were upper middle class employees. And virtually all the incentive programs have been aimed at disadvantaged or deprived groups. So this goes to the point, I think, that when there are these public health interventions, the middle classes will pick up on them and do them better, which will increase health inequality. And that the people from low socioeconomic status often will just take the money, and then when the program ends, they'll go back to their previous behaviours. So I think this is something where there are benefits while the monies are there. Whether it's worth doing it is an economic judgment, but you're right to be sceptical about them.
I have a question about life expectancy. According to these figures, we can see that clearly we can see that the increasing trend. So everybody will agree when the time goes on, the life expectancy will increase definitely because the science technology advancing. Well, everybody agrees that. But my question is, if we look back or look forward 2 ways, retrospectively or look forward, we can think like 5,000 years ago. So maybe we don't have that record, maybe 1,000 years ago. So how about the difference between race? So we can see there are 4 categories on the left-hand side. It's a big gap. So maybe 500 years ago, we still have this similar pattern.
Yeah.
Or maybe this is not more interesting. More interesting is we can look forward 500 years later or 1,000 years later. So can I say after 1,000 years, this gap will be very, very small, very, very close among all the race categories?
Yeah. Well, very interesting. So I don't think I don't think we know how to look back. And if you look back, what we find in bones, I think it's hard to, and people do try to estimate the age of the skeletons and the age of death that the skeletons they find, but very imprecise. Looking forward, well, there are 2 different views, actually, even in the short term. So we're talking about next generation or generation after. 2 different views going on. One is life expectancy is rising very quickly in a way that no one had understood, and technological advance will continue. Human ingenuity is more than ever. We'll find more life-saving, more life-preserving technologies. Life expectancy will go up and up and up and up and up. So that's the optimistic view. And in fact, life expectancy people keep thinking it's got to stop soon. And it hasn't. So life expectancy has been going up and up and up. All over the world. The AIDS epidemic stopped it for a while in Africa, but now life expectancy in Africa is going back up again. And that's the optimistic view. But you also hear, certainly people in the UK say this, I don't know if it's also said here, but sometimes it's said that teenagers today are going to be the first generation that don't live as long as their parents. Is it familiar thought? Okay, so why is that? Well, teenagers today, you know what they're like. It's things about behaviour, nutrition. There's some work that's been done on height, and so most places in the world, height has been increasing. So children are taller than their parents. And this is true all around the world, and in some cases it's spectacular. So in Ireland, for example, children are now 8-9 inches taller than their grandparents were. And so this is thought to be also the nutrition lifestyle. So people are growing taller in most parts of the world, but in the United States they've stopped growing taller. And it is thought that this has got something to do with vitamin intake in teenage years. The American diet has been one of a lot of meat and lots of carbohydrates, and particularly teenagers who can choose their own food tend to choose not to eat green vegetables. And this is then affecting height, and if it's affecting height, it's likely to be affecting other things as well. Talking to the students today, see that there's a swinging back of interest in nutrition and return to eating more things that grow locally and so on. So maybe this is just a temporary measure. But this shows really how difficult life expectancy is as a measure. Because if children who are born today, what's the life expectancy going to be? So the optimistic estimate is it will be about, on average they'll live to about 85. Say if life expectancy continues to grow, maybe 90. On the other hand, if it stops and it's in reverse, it'll be 70. And who's to say which one of these is right? It's very likely that if life expectancy starts going down, health inequalities will get worse, and that the wealthy and the well-informed will continue to have better behaviours than disadvantaged and deprived groups. So falling life expectancy will probably be felt disproportionately, although of course we don't know that for sure. So I can't even tell you what's going to happen in 50 years' time. So for 5,000 years, I have no idea. No idea.
We'll have one last question.
I noticed that so far all the explanations of life expectancy that you gave was in terms of, well, different medical intervention, but so far you have said nothing about culture.
Mm-hmm.
But when I look at that, all these different communities also have very distinct cultural practices.
Mm-hmm.
So could you say something about how culture changes these, or?
Okay, that's a good point, and thank you for raising it, because I realise I said Marmot has 3 explanations of the social gradients in health, and I only gave you 2 of them. So the 2 I gave you, one was pure status, another was control over your life. The third is social networks, social support. And his view is people who have a lot of social support will live longer than those who have less social support. And one of his examples to try and defend this is what happened in Russia after the fall of the communist regime. And life expectancy, this is one of the few places where life expectancy fell dramatically. And when communism ended, life expectancy for men in Russia fell by about 10 years, and life expectancy for women fell only by about 3 or 4 years. So there's an interesting question about what made this difference. So why was it that life expectancy for men fell so dramatically, not for women? And Marmot suggests that so he makes a background assumption, which some of you may think is wrong, but anyway, see if this rings true. It's about the formation of social networks. And how do people form their social networks? And Marmot says it's different for men and women. So men tend to form their social networks through their work and through their wives. Women have social networks through their families, so the women are much more likely to be on the phone to mothers, daughters, sisters, aunts, than men would be to brothers, fathers, sons. And women also tend to remain friends with people they used to work with but don't any longer, to a much greater degree than men do. So this is significant. So, because the claim is that men form social networks through their work and through their wives. Women have social networks in a much more complex way. So, what happened at the fall of communism was that people who had a guaranteed job, many of them were put out of work. And it's a job that they had thought for life, and for men, this was a tragic thing to lose their job. Women were more used to being in and out of the workforce because of maternity, part-time jobs. So if women losing the job was a blow, but not such a blow to their status as it was for men. But the real problem was social networks. So if men lost their job, they lost half their social support network, whereas women kept theirs intact because it didn't depend on their job. So Marmot suggests that men who were put out of work lost much of their social support network, and then became fairly intolerable at home, drinking too much, becoming violent, abusive, kicked out of the family home, so they lost the other half, and then went to live with other men in similar circumstances in crowded accommodation where they drank too much and fought and so on. And so and was susceptible to infection, and so lots of different causes of death that he thinks can be attributed to losing social networks. So what this slide might correlate with is a much richer set of social networks for Hispanic Americans than for white Americans or black Americans. And that alone could possibly explain at least part of the difference. So it's not exactly culture, but it's a difference in culture that affects different social networks. And you can see how it works. So if you're under great stress and you're on your own, that stress is compounded. But if you're under great stress and someone can look after your kids for you, so the final thought, I know I'm overstaying my welcome, but I'm repeating out something I said at the session at lunchtime, but the pre-modern medicine, by which I mean pre-antibiotics, there was relatively little doctors could do for individuals. Of course, if you need surgery or counselling, they could refer you. But if you had a medical condition, the thing that you needed to do more than anything else is rest. So if you're ill, you need to rest. I informally reported earlier today something one medical historian said, which was in pre-modern times, there were really 4 things that doctors would say to you. One is, put something hot on it, put something cold on it, take plenty of rest, or take plenty of exercise. And that was about all they had in our armoury, which was a modern version of the theory of the 4 humors. But the important one here is taking rest. But if you're on your own and you don't have a social support network, if you're a young mother without family around you, what does it even mean to say, we're going to take rest? Or if you're the only wage earner in the family and you don't have sick pay, what does it mean to take rest? So if you have a social network around you, that allows you to take rest, allows you to recover. If you don't have a social network, it compounds the problem, likely to lead to further medical problems. So that's just one way in which social networks help. But I think there's just another psychological effect, that if you have people around you who love you and support you, you feel better about your life, you feel better about things, and they can help you put things in perspective and so on. You're less likely to brood on issues. So I think social networks are very important. And one thing Marmot says is that in the social in the Whitehall study, the people at the higher end of the spectrum have higher levels of social support than people at the lower level within their workplace, and as they have more people that will help them. And I didn't believe this until I became dean of my faculty and found all of these people willing to help me with all sorts of things, which I just hadn't expected at all. So in one way, of course, it's a terrible job, very hard. In another case, it's the easiest job I've ever had, because if I need something done, there's someone probably who'll do it for me. There's a great, within the gradients of the support networks, they're not the same as a family support network, but any type of support network seems to be good, at least for some aspects of your well-being, for your health.
Well, Joe, thank you very much. Another round of applause.
We could go on for a long time, but in the great Southern tradition, we do have some gifts, parting gifts for you. This is a box with wrapping paper on it. In the current budget cuts, we couldn't put anything into it, but it looks good on camera. No, just kidding. And then just to prove to the folks at London that you have folks here in Tennessee that love you and support you is the status of honorary professor in the College of Public Health. So now you are officially a leading voice in public health. In philosophy and humanities for supporting tonight. We don't have any more Leading Voices lectures this year. We do have a special lecture at noon on April 15th. Dr. Jenny Dyer, the Executive Director of Hope Through Healing Hands, will be talking about Saving Mothers and Child, Why Planning Families is Critical in Developing Nations. And she's going to be talking particularly about the role of faith-based institutions in developing countries and planning families. That will be on the ETSU campus. I'll send out an email. But thank you all for being here tonight. Thanks again, John.